Welcome to Week 9, Nursing 103, Chapter 80, Sensory System Disorders. All right, let's get this started then. Would help if I hit the right button. There we go. Come on. Sensory System Disorders. Here we go. So, sensory system. Let's start with the basics here. You have 5 senses, only 4 of which should you be using in nursing and patient care. Right? Sight, hearing, touch, and smell. It's almost a universal constant. You should never purposefully taste your patient. But all of these pieces for the nurse, the sight, hearing, touch, and smell, are all part of assessment of the patient. For the patient or humanity in general, the 5 senses all play an important part in our interactions with the rest of the world. So a bit more of a breakdown here. Receptors are located peripherally for touch, for hearing, taste, smell. All these are peripheral. What I mean by peripheral is, so consider, all right, I hold my finger up here and I touch that. Okay, where do I feel that? Do I feel it here? No, I feel it up here. So these the receptors are located at the periphery, at the outside, but they are conducted to and then processed in the central nervous system. Right? When we talk about pain, you hear things like phantom pain. Right? Recall that the pain is not actually felt at the site of the stimulus, but it's felt in the brain. It's processed and interpreted by the brain. So let's start with the windows to the soul. And one of the, I will use the term normal patient, meaning someone without a disorder. So vision. It is it's one of our major senses for interacting with the world around us and also identifying danger. Okay? The tests that we would be looking at for vision, visual acuity. You noted I had my glasses on. I take them off doing these videos because it gets a weird reflection and it's distracting to me when I see myself in the corner of the screen. So visual acuity. So how well can you see? Well, I believe everyone by this point in their lives has had a vision test at one time or another. Refractive exams, ophthalmoscopic examinations, or ophthalmoscopic, depending on how you want to pronounce that. Using a scope, so ophthalmo, and we're looking at the eye, and then a scope. And these are visual examinations of the structures of the eye. Other tests that we may see done, retinal angiogram. Now, we've discussed before about a surgery is a surgery is a surgery. And again, an angio is an angio is an angio. We are looking at the vasculature. Okay. And many of the risks are the same, as you recall, and we will touch on this again a little bit later in this lecture. So remember that a surgery is a surgery is a surgery. The difference is location. So you have your 5 common things to all surgeries: pain, inflammation, hemorrhage, infection, and anesthesia complications. All 5 of those are common to all surgeries. In the angio, we are looking at the vasculature, and if using radiopaque dyes to do this, then you have the same allergy pieces that you need to be checking. Okay. Binocular ultrasound. So a retinal angiogram, using radiation to see these, an ocular ultrasound using sound waves to give a picture of the structures of the eye. And then electroretinogram, we're looking at the electrical activity that takes place in the eye. Because as you recall, we're an amazing machine, and there's a whole lot of electricity that goes on between muscles in the brain and nerves in the brain and back. These are all electrical impulses that are being sent along these nerve impulses to be processed. Ear and hearing tests. So we'll start with the otoscopic examination. So using an otoscope, it's a visual examination of the external structures of the ear. You should not be able to see any internal structures of the ear with an otoscope. If you can see the internal structures, there is a big problem. There's audiometry, or your hearing test. Caloric studies, electronic stegmography, and ENG. Let's call it an ENG. And again, imaging, MRI, which is magnetic radiation, not ionizing radiation. An MRI to show the structures of the ear. And then the last piece here, evaluation of proprioception. Proprioception, our ability to determine the direction in which a sound is coming from. You will often see patients who have hearing loss on one side or another, or their sense of proprioception is impaired. Much like the patient who has lost vision in one eye or the other, they have a tendency to scan. Often it is it's not intentional, but they will scan to attempt to determine where a sound is coming from. As we get back to on-campus learning, you may find when talking to me that I scan because I'm missing quite a bit of hearing in my right ear. More about that later, I'm sure. So, common medical treatments. Eye patching for injury to the eye, an eye patch to cover, to rest that eye, to keep irritants out, various reasons why a patient might have an eye patch. Cotton-tipped applicators. So these are actually parts of treatment, but a cotton-tipped applicator to clear debris or to apply medications. Dog. Irrigations of the ear or of the eye, but irrigations of the ear to clear foreign bodies or substance buildup. Okay, so true or false? The client with one eye patched is allowed to drive. My apologies for the lawnmower in the background there. That would be false. One eye patched, client will have a loss of depth perception. Just a moment here. Okay, there we are back again. Let's go back and see if I can. There we are. Current slide. Fiddly poo. All right. All right. So the client with one eye patched, back to this. So with one eye patched, loss of depth perception. But Sean, I know somebody who only has one eye, who has a glass eye that still drives. All right. So what we're talking about here is someone with an acute condition who has just had the patch applied. Someone who has lost vision in one eye for an extended period of time has learned to adapt. It is in the short term after that loss of vision or the eye patch that they're the highest danger of all driving, right? And then, well, of course, with both eyes patched, there's a distinct piece of danger there in interacting with the outside world. A client without vision in both eyes, of course, would not be able to drive. So here's a little homework assignment for you to understand what your patient is going through at this time. Take a bandana, an eye patch, whatever it happens to be, and cover one eye. It can be your dominant eye, your non-dominant eye, whichever one, and move around in your environment and make it an environment that you are familiar with. Okay, just to make it a little safer for you. But then note the things that you run into, the difficulties in depth perception. Consider that when you have one eye patched, or loss of vision in one eye, like here, there's a whole lot that goes on over here that I cannot see unless I am scanning. So even walking down the hallway or going through a door frame in an area that I am familiar with, I can still have an increased danger interacting with my surroundings. So just try that. Go around for a bit with one eye covered over, just to see what it's like for this patient who has, through an eye patch or through an inflammatory disease or surgery, has lost vision in one eye. So, common surgical treatments. Eye surgeries. Our first, enucleation. That's the surgical removal of the eye. The eye's been cut out. So again, not only do you have these surgical risks, the preoperative care for this patient, providing comfort, providing education. Post-operative care, we're going to be working to provide safety for the patient as well, and that post-operative teaching plus scanning for our 5 common issues for surgery. With ear surgeries, one of the more, I wouldn't say more common, but the cochlear implant, used to restore hearing to someone who has lost their hearing or who was born without hearing. There is a whole debate around the cochlear implant and issues with this in the deaf community. I'll leave that for you to do some more research on. But again, we have preoperative and postoperative care for ear surgeries, not just the cochlear implant, but any ear surgery that we'd be looking at. And again, there's the patient teaching, there's the providing safety and monitoring for the 5 common complications of surgery, plus those complications that are specific to the surgery that you're talking about. Nursing process, right? Remember, AND-PIE, AND-PIE, data collection, As our assessment. From that, we get our nursing diagnosis, and then we go into planning and implementation again. So for the visually impaired, for those that would be permanently visually impaired, or for our patients who come in who are not just newly impaired, but we are providing care for, let's say we're providing care for a blind patient who has had an abdominal surgery. Okay. What sort of things do we provide for that patient? If our patient is in our care, has lost their vision, and we're preparing them to rejoin, to go home, what things are we providing? What education? What services? In this case, Braille, learning. We wouldn't be as nurses necessarily doing the teaching someone how to read Braille, but we may be providing them with patient education materials in Braille, guide dogs, the white cane, which the white cane serves multiple purposes. One is it acts as a sensory extension, replacing sight with the sensory input from the cane and the sense of touch. But it also serves as a visual cue to those around that patient that patient or that person is not necessarily going to see them. For the hearing impaired, hearing aids, speech reading, lip reading, sign language. Now, I want to take this moment to give you a little nursing pointer. Bob, that's Bob again. Bob is very hard of hearing, wears hearing aids. Well, Bob's supposed to wear hearing aids. Bob doesn't really wear his hearing aids. They tend to stay at home on the nightstand. Bob is admitted to your facility. He does not have his hearing aids. Bob's also getting a little old, and he's not so good at lip reading because his eyesight is starting to go. Right? Bob never learned sign language because he's not deaf. Right? Bob has no hearing aids. We need to communicate with Bob. We need to provide patient education. We need to get information from Bob. We're trying to collect data. Part of that is getting his history. How do we communicate with Bob? Do we scream in his face? Okay, well, very often we do, a voice. Or do we get another method of communication or amplification? I mean, hearing aids, they are, they're fit to the patient. There are a number of different things, but we as nurses carry one thing around our necks or in our pockets that we can use to facilitate communication with Bob. This is it right here. The stethoscope. What? So, Bob is very hard of hearing. Bob's hearing aids are at home. Here's what we do. We clean off the earpieces from our hearing aid. We make sure to set them in, or from our hearing aid, from our stethoscope. We make sure to set them in to Bob's ears properly, which means when it goes onto Bob's head, the earpieces point slightly forward. We make sure that the earpieces are on there nice and tight too, because nothing's as much fun as getting the sharp end of a stethoscope in your ear canal. Put them on Bob's ears, get a nice good fit, and then we speak into the bell. Hey, Bob. So tell me what brings you in here today? Stethoscope amplifies sound. This is a great and easy way. Of course, you got to clean your you've got to clean your earpieces. but it's an easy way for someone who is not completely deaf to get amplified sound when they don't have their hearing aids. And then the evaluation. Did it work? Nursing process. I swear we've heard that before. And we'll continue to hear it over and over again because, well, that's what we do. Okay, so here's a question. When we are caring for a patient who is experiencing a hearing impairment, it may be an acute hearing impairment, right? Do we face the client on the same level? Do we speak really gently in a quiet and darkened room? Do we keep a very rigid posture? Don't use any hand motions or any facial expressions? Okay. Do we just keep repeating the same word over and over? Or do we wait for them to notice rather than getting their attention? Okay, what do you think? A, B, C, D, or E? And the best answer is A, same level. Because remember that a patient who is hard of hearing may do some lip reading as well. Okay, we get their attention before starting to speak, rather than getting halfway through our spiel before Bob says, huh? Right? Also, getting the client's attention versus just waiting for them to notice, which is going to startle them more. It has been my experience that if I just stand like a creeper and wait for them to notice me, it tends to be more startling than if I tap Bob on the shoulder or on the foot. Get enough light so that the client can see the face, can see the lips move. Drop background noise, cut down on the competing sounds. Right? Chewing, smoking, lollipops. Now this last piece, this is a bit more difficult during the times of COVID-19. Do not cover it while talking. What is just about everybody in healthcare wearing right now? A face mask to prevent transmission of COVID-19. So in this case, this complicates the lip reading portion of it. So again, this may be where a stethoscope comes in really handy for your patient, okay, to be able to communicate. Speak slowly and clearly. Not just the one word over and over that they're not understanding, the entire phrase, so that they can pick up what you're saying through context. Restate. If they're not understanding those words, restate it. Okay. And then verify that Bob understands what you're talking about. And don't just read it. And to verify understanding, you want to use open-ended questions or more open-ended questions. Questions that can be answered with a yes or a no. You will likely get a yes or a no, but it will not necessarily mean that the client understands, because yes or no is really easy. If I have not mentioned it previously, allow me to educate you. Your patients, your clients, those that you take care of, will lie to you at every chance they get. Now, I'm going to qualify this. The catchphrase is, your patients are lying liars that lie a lot. I'm not saying that everyone is deceitful. What I'm saying is that very often your patient will give you false or bad information or withhold information. And withholding information is the lie of omission. Why might a patient do this? They may be embarrassed. Right? When the nurse-patient relationship, you as nurses come into this from a position of power. When you have developed the nurse-patient relationship with your clients, you will often find that your clients want to, they don't want you to be disappointed. They don't want you to be mad. So they will give you the information that they think you want to hear. Or they may not think that it is important, so they just don't tell you about it. Again, these, whether or not the lie is intentional, or even that they know that they're doing it, it is happening. The misinformation or lack of information is there. So verifying understanding, a patient with, in this case, a patient with hearing disorder or hearing impairment may not understand completely what you have said, or they may have misheard, and will answer answer yes or no based on that. They may be embarrassed that they can't hear everything that you're saying and just nod in agreement. So these pieces, verification of understanding, make it an open-ended question, something that requires more than a yes or no to answer. That will help you and the patient by cutting down on confusion, misinformation that can occur during your patient interactions. Right, so treatments for the eye, right? You got the ophthalmologist, the optometrist, the optician. The ophthalmologist works on the eye, prescribes. The optometrist is really working with visual acuity and doesn't make the glasses, but fixes the prescription for the glasses. An optician, that's the one that makes the glasses, okay? Or makes the contacts. These are the breakdown here. The ophthalmologist treats the diseases of the eye, where an optometrist is more about visual acuity and correction there. So refractive errors. Now we're going to play with a little bit of whiteboard, right? So when light rays focus in front of or behind the retina, owing to variations in the shape of the lens. So I'm going to stop the share here for a second. We're going to go to a whiteboard. Okay. And whiteboard. Okay, here we go. So again, I do not promise great drawings here, but let's draw an eyeball. Okay, let's erase that eyeball and try that again. Okay. All right. It's still sort of a funky eyeball, but we'll go with this. All right, we've got an eyeball. We've got a lens here, okay? And then, let's do a retina back here, okay? All right, so we've got an eyeball with a lens, we got a retina. All right. Oh, come on. And let's take, first we have a ray of light. And then We have another ray of light. Okay. Okay, so the light comes in, and here it focuses on the retina. That's everything perfect. The lens is perfectly shaped. The eye is focusing correctly. That light is focused on the retina, right? So we've got good acuity. Right? We've got all this. I mean, okay, let me. All right. So focus is there. Right? Now let's say that our lens is a little out of shape. All right. Come on. There we go. Let's just say our lens is a little out of shape, and that ray of light is not focused as well, okay, on the retina. Right? So then we have a blurry image. Or eraser. Come on. Let's say we have another issue, and it focuses. So that first one would focus behind the retina. Right? This one would focus in front of the retina. Right? Both resulting in blurry images. Images at different distances would be focused, and the further images would be blurry, or the closer images would be blurry. Okay, so I mean, there's the basic shape of our eye, and we're talking about lens here. Or say my patient has an astigmatism. Everything else is working fine, but the surface of the lens is distorted, which then leads to misfocus and the blurry image again. Does that make sense? I hope that does. So let's pop back here. I'm gonna put this back up. All right, stop that share. Okay, and we'll go back to our PowerPoint. Right. Okay. Whoop. Now, all right. So, variation in the shape of the lens causes the light to focus at different lengths, cause blurry images. So we have myopia, hyperopia, astigmatism. That's the irregular lens, and the presbyopia. Right? So how do we fix that? Well, with good old glasses. And the older you get, you may need the bifocals. Just saying, it happens. Contact lenses. So lens, sort of in the name, they're directly in contact with the eye to correct the focus. And last but not least, we've got surgery. One of the more common, probably one of the most common eye surgeries in this day and age is the LASIK type surgeries. So reshaping the lens with a laser to correct the focus errors. I myself had LASIK about 12 years ago. And it lasted for about 8 years before I started needing glasses again, and that was more for reading. So most common LASIK surgery, there are side effects, the common side effects of surgeries, though As far as anesthesia goes, there's really not much for that, and not much for hemorrhage if it's done right. But these are all potential complications. Inflammatory disorders. So inflammation, yet again, one more time, become very familiar with inflammation and the processes, the process of inflammation, what can cause inflammation, and how do we treat inflammation, right? First off, let's talk about conjunctivitis. What is conjunctivitis? Have you heard of pink eye? Right? Well, conjunctivitis itself is inflammation of the conjunctiva. Now that tends to come with dilated capillaries because, hey, we have inflammation going on. Capillaries dilate. But when we talk about pink eye, and anybody who's had kids or ever experienced pink eye just probably shuddered and moved back from their screen a little bit. It's sort of like saying lice. Where the pink eye that we all seem to be the most afraid of is bacterial. It spreads so easily. That's the one that has a tendency to make runs through schools and through families. But other things can cause conjunctivitis. Chemical exposures, viral, which tends to be a little harder to transmit. Trauma. All these things can cause allergic reactions. Can cause conjunctivitis. So it's not just one thing. When we really think about pink eye, we're talking bacterial conjunctivitis. Trachoma, blepharitis, hordeolum. So these are all inflammatory disorders. Become familiar with those in your book. Probably the most common that we see in nursing is conjunctivitis. All right, so for a client with conjunctivitis, rubbing the infected eye gently relieves pain and itching. What do you think? Should we be rubbing the infected eye? Should the patient be rubbing the infected eye? No. Can cause abrasions, can cause scarring. Not only that, but if it's bacterial, then the bacteria get on your hands and you touch things and other people touch things and they touch their faces many times a day. Sometimes they scratch or rub their eyes or scratch. Then we have the passing on of the bacterial conjunctivitis. If you're using eye drops, don't touch the eyeball with the dropper. If you are providing the eye drops, and you'll get this in second term as medication, you do not touch the eye with the dropper. You do not, however, hold the dropper up 10 inches from the surface of the eye and then let a drop go. Touching the eye can contaminate the solution. Holding the dropper up 10 inches above the eye and just bomb sighting it in is just an evil thing to do, because that drop picks up speed and hits the eyeball with the force of a Mack truck, or that's what the patient feels like. And then once the partially used eye drops are done, get rid of them. Right? Solution can become contaminated. Right? If it becomes contaminated with bacteria or whatever, and then you're putting that directly into the eyeball, we're creating an infection. Or if you have gotten through bacterial conjunctivitis and then you grab, a couple of months later, you grab your bottle of Visine that you were using to help soothe the eyes, and then drop that in there, well, then you've just given yourself pink eye again. And that's sort of like adding insult to injury, right? Structural disorders, right? So here we're talking about the eyelid itself. So the outward turning, and I'm going to say middle school. maybe grade school, hell, could be college too. Everybody knows that one kid. Or maybe you were that one kid who would flip their eyeballs, or their eyelids up and out, and have the inside showing, and then gross out to all the people around them. Okay, it's the outward turning of the eyelid. Should not happen normally. Entropy on the inward turnings, to where the margin of the eyelid is turning in next to the eyeball. This can lead to irritation and scarring and bacteria. And then ptosis, the P is silent. That is the drooping of the upper eyelid. Now, this can come on with neurologic or structural damage. And the one I would want to, as a good visual example, Forrest Whitaker. If you have seen him in his movies or his TV shows, you will see that it would be his left eye. You can see that in many scenes, that left eyelid droops a little bit. Don't know the medical history, but you can see that he has developed ptosis, and it seems that the later in the day the scene was shot, the more it droops. Glaucoma. So, increased pressure in the eye. Now, as you recall from our drawing, the eye, it's it's a nice little grape. It's a sac filled with fluid, and has some pretty important delicate structures within retina. And there's just enough fluid in there normally to allow the eyeball to keep its shape, so that the light can focus where it has to, and all the structures are held in place. Now, if that fluid pressure increases, then the patient ends up, one, with a lot of pain, and two, damage to the structures inside the eye. So if got chronic and acute glaucoma, secondary glaucoma. Okay, here's the time to hit primary versus secondary. So a secondary condition, right, is a condition that results as a side effect of something else. So secondary glaucoma, this would be increased fluid pressure in the eye that is the result of another condition. So secondaries, like renal failure. You may have renal failure secondary to uncontrolled diabetes, or the uncontrolled diabetes is the condition that's caused, the condition the patient has, but the effects of that condition cause damage to another system or cause something else to fail. In the secondary glaucoma, you may end up with the same thing, the microvascular complications of diabetes causing increased pressure in the eye. So the glaucoma would be secondary to the diabetes. Diabetes is the primary condition. Glaucoma, or the renal failure, or the whatever else it is the secondary condition. Nursing considerations for the patient with glaucoma. Okay, so a big one, pain. Another one, safety. Safety. Okay, with the pressure in the eye, with the increased pressure and the pain and the disturbance to the shape of the eye and the damage to the structures within, this can cause visual disturbances. May not be causing blindness right away. It will eventually cause blindness, but may not be causing blindness, but visual disturbances, loss of visual acuity, and the patient is at higher risk for injury due to the visual disturbances. Cataracts. Achoo. It is allergy season. Yay. So, an opacity or cloudiness of the lens. So, the part that lets light through, focuses it on the retina, right? So, a couple of treatments for cataracts. Cataract extraction, surgically go in and remove the cloudy part. Phacoemulsification, so injecting the area, re-emulsifying the lens nucleus to make it clearer, right, to allow light to pass through better. And here we have a lovely example of a cataract. You can see there's not much light getting through that. This patient is effectively blind. Bringing us into macular degeneration. Okay, so here now we have it's not the front end of the eye now. Now we're at the back end, the macula. So loss of central vision. So here's a concept for you to look at central vision, and you would need a pair of glasses that fit pretty close to your face, and then you put two dots right in the center of each lens. With those dots, now walk around with those glasses, the goggles on, with those dots. That the loss of central vision, the picture is not getting through, so the patient can't see many things that are happening. You've got age-related macular degeneration. Comes with age, wear and tear, and the structure is wearing down. And dry and wet macular degeneration. Those are outlined in your text. Trauma. Oh, rats. Yes, the eyes are incredibly important structures. They're actually pretty tough structures, but trauma can affect the eye as well as anything else. Got loss of central vision because I got fingerprints in the middle of my lenses. Yay. So contusions and hematomas. So you got bruising to the eye. Foreign bodies in the eye, around the eye, underneath the eyelids, things that aren't supposed to be there. With a foreign body penetration to the eye. That was one, a pencil. That's the one that sticks in my mind the most. Was forget running with scissors, walking with pencils. It was a fall, pencil went into the eye. Patient freaked out a lot. Well, if you have an eyeball phobia, that can really mess with you. But so we come in and to pick this patient up, and there's a pencil sticking out of their eyeball. In that case, we had to not only cover the damaged eye, but we also had to cover the good eye. Because think about this. You had a foreign body stuck in an eye, pencil sticking out there. And you didn't cover both eyes. Remember that your eyes track together. This gives us our stereo vision. This gives us our ability to judge distances, right? Our depth perception. Covering both eyes, because if we just cover the one eye and leave the good eye open as they are looking around, both eyes are moving at the same time, increasing the damage, increasing the trauma from the foreign body stuck in the eye. Chemical burns. These can happen really easily. times you might get chemical burns. Getting a face full of pepper spray. That's one. Not having the lid on the bleach bottle and setting it down and getting a splash in the face. Anytime you get a caustic or irritating chemical into the eye, it can cause the inflammation reaction, can cause chemical burns. Corneal abrasions. Actually, it happens more than you think, and it's a scratch across the cornea. It can be very painful. Can have a permanent visual impairment if much scar tissue forms. So treatment of the corneal abrasion is very important. And then detached retinas, which depending on cause, and it's where the retina detaches from the back of the eyeball. Now, light can no longer focus on the retina as it should because it's flapping, it's out of position. It can be repaired in many cases. It's actually an amazingly delicate surgery done through a small port put into the eye, and the surgeon goes in and reattaches the retina to the back of the eyeball. It's incredible surgery. So what do we think? Do we need to use extreme caution when putting any type of medication into the eye? Yeah, that's kind of a no-brainer there, right? But for different reasons. So GLIAC, testing for occult blood. Some of you may have done this as nursing assistants. If not, stool sample is taken, placed on a developer card, and this developer solution is placed on there. And if it turns blue, you've got blood. Okay. They come in little bottles, about like this. They may look to your patient like eye drops. The patient may pick them up and try to use them as eye drops because their eyes are irritable. And then their eyes get really irritable. These solutions should never, ever, ever be left at the patient's bedside or where a patient can get a hold of them. Okay, treatment, ear, right? Otologist, someone who treats the ear. An audiologist, someone who is focused on hearing, assessing and treating hearing loss. And an otorhinolaryngologist. Otorhinolaryngologist. That's your ENT, your ear, nose, and throat. Or your otolaryngologist, your ear and throat specialist. Now we're going to get into hearing loss, something that some of us may have more experience with than others, from the patient perspective. So the types of hearing loss, conductive hearing loss. So you got air conduction, you got bone conduction. What in the heck am I talking about? Guess what? It's time to do another whiteboard. Okay, we'll go to a share screen here. Whiteboard. All right. Take the eyeball away. And now we're going to draw an ear, sort of. All right. It's going to be a rather odd looking ear, but so here we have and draw an ear canal, and it's going to go way back here. Okay. External ear, external auditory canal. We have next the tympanic membrane. And we have 3 bones, which I'm not going to attempt to draw as they actually look. And then we have an oval window here. So, all right, we'll draw these pieces in next. Okay. Here. So, external from here to here, all right? Middle ear, that's a D, right? And then and the inner ear. Okay. Now let's draw some sound. Okay, how am I going to draw sound on this one? All right, we have sound. These are sound waves. Okay, we have sound waves. So sound travels from its source to the ear, down the external auditory canal, and hits the tympanic membrane. The tympanic membrane is the border. It is it's at once part of the external ear and the middle ear. In the middle ear, we have the tympanic membrane. We have 1, 2, 3 little bones. Let's just draw a little, I don't know, there's a connection there, right? And then sound waves that travel in through, or waves that travel in through here. All right. So starts with a wave in the air. The sound travels. That wave hits the tympanic membrane, which vibrates. Okay. Now, this is not the most efficient system. There are a lot of parts to this to get the sound from out there to becoming an electrical impulse. So this causes the tympanic membrane to vibrate. Right? Those vibrations work through these 3 bones. So it comes from sound waves in the air to vibration. And that 3rd bone is connected to this oval window here, right? The oval window turns into vibration, which then causes the oval window to vibrate. And the inner ear, filled with fluid, turns the sound waves into vibrations, into waves in fluid, which then travel through the inner ear, through the labyrinth, and lining the labyrinth are these little hairs called cilia that vibrate with the waves in the fluid in the inner ear, which then turns those sound waves into our very last piece. Oh, come on. We have electrical impulses that are sent up to the hearing centers of the brain to be converted. So they're converted into electrical impulses, which are then read and interpreted in the brain. Again, not the most efficient system. We have sound waves, so variations in air pressure causing this membrane to vibrate, which in turn causes these bones to move to cause this oval window, this membrane, to vibrate, which causes waves in the fluid in the inner ear, which causes these cilia to vibrate, which turns into electrical impulses, which is then sent to the brain for interpretation. Okay? Not the most efficient system. And a breakdown in any one of these areas can cause hearing loss. So when we talk about air conduction, right? So let's say we have something in the external auditory canal that blocks the sound wave, right? Blocks that air pressure. It could be a buildup of cerumen or earwax. It could be a foreign body. But you see that if we have a blockage, it could even be a tumor or a growth of any sort, something to block that canal. Those sound waves don't get to the tympanic membrane, which then cannot vibrate because the sound waves are not hitting it, which means these bones don't vibrate, which means the oval window doesn't vibrate, and we don't form any waves, fluid waves in the inner ear, causing the cilia to vibrate, and we don't have any electrical impulses being sent to the brain. Now, let's say we have still got good conduction here. We don't have a blockage, but the tympanic membrane is broken. It has a hole in it. It is torn, or it is heavily scarred, which impairs its ability to vibrate. Any one of you who's ever played a drum and broken a drum head, this is really similar. If the drum head is broken, it doesn't vibrate, doesn't create the sound, or doesn't create the vibrations through these three bones, and it doesn't cause this the oval window to vibrate, creating the pressure, the fluid pressure waves, causing the cilia to vibrate, turning them into electrical impulses to be interpreted by the brain. Okay. Say my tympanic membrane is intact, but there's a problem with the three bones of the inner ear. Perhaps they are getting calcifications built up, which would impair their ability to vibrate, to move with each other. And if these bones can't move freely and can't vibrate, then I've got sound waves coming through. I may have a tympanic membrane that's vibrating, but the vibrations are not being passed on efficiently through these three bones. The oval window doesn't vibrate. We don't have fluid pressure, fluid pressure waves, the little sound waves in the fluid, causing the cilia to vibrate, no electrical conduction. Okay, so that would be bone conduction loss. Okay. Or the last piece with the inner ear, there is an issue with the oval window, or there is damage to the labyrinth or the cilia. So I might have good, I might have good conduction, passage of the sound waves. I could have good vibration of the tympanic membrane, the bones transmitting the vibrations through. But now my problem is here, being the oval window being scarred, or the cilia being damaged. If the sound, or if the pressure waves, the fluid waves are still getting around through here, but the cilia are damaged, they won't convert those waves into electrical energy to be processed by the brain, right? So these areas where you can lose hearing loss. And then the last piece would be nerve conduction. Everything from the external, middle, and inner ear is fine, but there is a problem here, and we do not have good connection from the inner ear to the area of the brain that is processing the sound. Or perhaps there is damage to that area of the brain, sound's not being processed. So there you have nerve conduction. All right, let's go back to the slides. I hope this is all making sense. Okay, so we got air conduction, bone conduction, sensory, so problem in the cochlea itself, or that labyrinth, the inner ear, right? Neural, so these would be that eighth cranial nerve from the cochlea to the brain for processing, or hearing loss in the central nervous system from brain damage, possibly stroke, possibly trauma, it could be brain tumor, things that would affect the brain itself. And then the last piece being functional hearing loss, which may be from a variety of causes. Right? So how do we prevent hearing loss? I myself wish I had a time machine so I could go back and tell younger me, hey, doofus, wear your hearing protection. All right. So prompt treatment of infectious diseases. Inflammation can cause more than just pain. It can cause lasting damage. Infectious disease, infection can cause inflammation. Inflammation can cause damage to those tissues and structures. So prompt treatment, utilizing antibiotics early in the course of an ear infection, not just hoping it'll get better or waiting until it does, but the prompt use and proper use of antibiotics early in an ear infection. And last piece to prevent the most common types of hearing loss is using ear protection. For those that work in industrial environments with lots of high level or lots of higher sound levels. Sorry, I'm losing my mind here. Those of us that are shooters or hunters or have spent time in the armed services wearing the hearing protection, not listening to your death metal at max 11 volume, all these things to protect the hearing, because once it's gone, it doesn't come back. So external ear, impacted earwax. So we talked about that already, right? You got a buildup of earwax, cerumen in the ear, which impairs the sound waves in the air, slows them down or stops them from reaching the tympanic membrane. Furnicles, so growth, big zit, if you will, in the external auditory canal, or impacting the external auditory canal, that causes that canal to be shrunk, so not as much of the sound wave is getting through. Foreign objects, things stuck in the ear. One of my absolute favorites is cockroaches in the ear. Yes, it happens a little more commonly than I am entirely comfortable with. But yes, insects getting in there. Cockroaches was a fun one in Texas. Coming into early winter, as the temperatures are starting to go down, the cockroaches were looking for warm places, and they were crawling into people's ears. There's a shudder for you. So external otitis externa, inflammation of the external ear, having that same effect where that inflammation reduces the size of the external auditory canal and impairs the sound waves getting through. Fungal infections, which can cause inflammation, and inflammation of the tympanic membrane can reduce its ability to vibrate, thereby transmitting those vibrations through the bones to the oval window, into the cochlea, into the labyrinth, to cause those fluid waves, to cause the cilia to vibrate, to send the impulses to the brain. Punctured tympanic membrane. That's what I'm talking about. It's a drum head, and if there's a hole in the drum head, it does not vibrate efficiently. Right? In some cases, this may be done as a treatment to other things, myringotomy, where they're putting a hole in the tympanic membrane to relieve pressure. It will decrease the patient's ability to hear until that hole is finally closed, and or the scar tissue buildup may result in permanent hearing loss. And then the last piece, piercing the earlobes. It is technically a disorder. I will say that from a nursing standpoint, I make no judgments, but if your earlobes are gauged out to where you can put a Coke can through your earlobes, okay, not a good thing for nursing practice, and it's not due to how it looks, right? Because everybody's got their opinions on that. What it is it provides a ready handle for that demented or aggressive patient to now own you. Get their finger in through that hole, knock out that pretty gauge plug, and now they have a tight grip on your head and can take you wherever they want you to go. So piercing the earlobes, in that case, that can be a safety thing for the healthcare professional. The other piece is that piercing the earlobes, it is a piercing. It can get infected and it can cause inflammation. Middle ear, so otitis media, fairly common with children, and that is a middle ear infection. Okay? So of the types, you can have acute purulent, meaning pus formation, chronic inflammation of the middle ear, chronic inflammation of the middle ear with pus, and may require tympanoplasty to rebuild the tympanic membrane to address damage done by this inflammation. The last for the middle ear, otosclerosis. So we talked about the three little bones developing calcification so that they can't move together as easily. This is where we're talking about otosclerosis, hardening of those bones, calcifications that impair the movement of the little joints between those three bones, which can cause the impairment of vibration, so you don't get the vibration traveling from the tympanic membrane to the oval window of the inner ear. Inner ear, otitis interna. So you see, we've gone from external ear, otitis externa, middle ear, inner ear, right? Otitis externa, otitis media, otitis interna. Right? Inflammation of the middle ear. So with inflammation, as you recall from the diagram, inflammation of the middle ear can impair the cilia's ability to vibrate and take those fluid waves and turn them into electrical impulses. With chronic inflammation, the cilia themselves can be damaged and you have permanent hearing loss. Drugs. Right? Some of our drugs may be toxic to other structures, and they may be completely unrelated to what's being treated. So as you are rolling through your pharmacology, make sure that you understand when a drug is listed as ototoxic, what its effect can be. It's nephrotoxic or hepatotoxic, what those effects can be and what to look for. In the case of ototoxic, we're talking about hearing loss. So I want to pose a question to you. I have two patients. I have Bob. Bob's getting up there. Bob's got some hearing loss already. When I walk in to talk to Bob, I've got to raise my voice so that Bob can understand me. And then I have Bob's brother, same age, perfect hearing. When I walk in and talk to Bob's brother, we'll call Bob's brother Joe. Okay, so I got Bob, I got Joe. When I walk in and I talk to Joe, I'm speaking in a normal voice. Joe can hear me just fine. Both of them are receiving a drug that could be ototoxic. Who do I have to assess more closely for the ototoxicity? Bob. All right, why Bob? Why Bob? Why would I have to assess Bob more closely? Is it because he already has hearing loss and that hearing loss makes him more susceptible? It is because Bob already has hearing loss, but it's not because the hearing loss makes him more susceptible to the ototoxic drug. Consider, if I walk in and I say, "Hey Bob, how's it going?" Bob says, "Huh?" And I said, "Oh yes, Bob's hard of hearing. Hey Bob, how's it going?" Okay, that is fairly normal. If I walk into Joe and say, "Hey Bob," or "Hey Joe, how's it going?" And Joe says, "Huh? What did you say?" Okay, it is more evident in Joe that Joe is having some hearing loss. Whereas with Bob, I've already got hearing loss, so I need to assess a little more closely with Bob because I'm already having to raise my voice. Whereas with Joe, if I had to raise my voice to talk to him, oh, that's a change in condition. In Bob, the change in condition is not as evident. I'm hoping that made sense. Inner ear disorders, Meniere's. Right? So this is a rather unfortunate condition. However, it is treatable, not curable, but treatable. In which, because the inner ear is for more than just hearing, the inner ear helps us with balance. With Meniere's, the patient may be afraid to stand, walk, or go anywhere because Vertigo can come on like that and without any warning, and then the patient is at greater risk for falling. If I have a patient who I know has Meniere's disease, I am especially worried about that patient in the realm of safety, because I know that they can get vertigo and tip over at any moment. So what do you think? Symptoms not treatable? All right, well, I kind of telegraphed that one already. Can cause significant vertigo, nausea, tinnitus, but they are treatable, not curable, not curable as such. We treat with palliative medications to treat the symptoms. And last but not least, are other special senses, and how might they affect our patient? So, sense of touch. Right? How might this affect my patient or affect my patient's care? So, if my patient has a tactile disorder, right? If they have numbness, loss of sensation, that creates a greater risk of injury for the patient. Those who have experienced life without any sensory disorders may not realize or may not think about it. So let's think, if you go to pick up the coffee pot and you touch the glass and ow, that's hot, right? You pull away. It's body's natural reaction. Oh, I've got pain. Pain is bad. Pull away from the pain. Because that screaming hot coffee pot can cause burns. Burns can impair the integrity of the skin. Skin opens up. It allows for infection and potential permanent damage to the host. Patient with a tactile disorder doesn't get that input and may end up with a burn. Right? Sense of taste. This can affect the patient in a couple of ways. I want you to consider your elderly patients in a care home at this point. One of the most common issues we have with our elderly patients is nutrition, right? Getting sufficient food into the patient to meet their metabolic demands. As with age, can come a decrease in gustation, or the gustatory sense, the sense of taste, which can lead to an impairment in appetite because nothing tastes really well. Nothing tastes really good. Now consider the table at most nursing homes. The food is rather bland. There's generally no salt on the table. There's not much really to spice things up, and therefore the food is really fairly tasteless. And that often leads to cases where patients just are not eating because the food doesn't taste good. This can also come in with courses of medications. My personal experience is with Keflex or antibiotics. When I'm on antibiotics, it affects the taste of food. And I do not eat nearly as much when I'm on these medications because the food doesn't taste good. Last piece, olfaction, the sense of smell. Smell is another one of those pieces that is very important for safety. Okay, so what could I mean by that? All right. You're at home at night, you smell smoke. You don't have a fireplace. That is, that's a sense that, okay, there's smoke, something is burning. Or you're at home and you smell rotten eggs. And you remember from the PSA that, oh, gas leak, rotten eggs, sulfur smell. Time to get out, get to safety. your sense of smell can play not only a big part in enjoyment of your environment when things smell good, but when things smell bad or dangerous, if you don't have the sense of smell, you run that much higher risk. Voila. That is that for sensory disorders. We have one more lecture to go, and I'll be getting to that next. We are capping off week 9, headed into week 10, and then to finals. Enjoy your weekend.